This video is going to discuss a single arch edentulous guided smile case completed by Dr. Lee. Thank you very much, Dr. Lee, for the photos and some wonderful documentation. We're going to discuss just real quickly the records for Edentulous, which is always a dual scan. This is a maxillary surgery. So a dual scan always. It's the only way to complete a uh, guided surgery unless you're bone supported. If you're tissue supported, you have to have a dual scan. There are details on the website of how to perform this. And use the checklist, please. So normal photographs, full face, full smile, profile. We like to have a profile picture on Edentulous because lip support is often a conversation. And then retracted left, right, center. And then I had the two images here of the STL files that were sent. And because the patient has a lower partial, we would not want this scan here. Rather, we don't need this scan because we really want to have the denture pressed against the tissue, especially in the posterior. That's where the issue usually is, the denture dropping down in the posterior or there's a gap. So not that record, but we do want this record in this case because the patient has a lower partial, patient has worked out the bite, and the denture fits. We want to press it against the tissue during the dual scan, right? And then here's the dual scan, appliance scanned alone, appliance scanned to the mouth, dual, and off we go to designing the case, planning, and so forth. So let's fast forward to surgery. On an edentulous case, the first thing that you'll do is to seat the pin guide, try it in. I don't have an image here, but the pin guide is already seated here, but you try in the pin guide, it's going to fit exactly like the denture. No rocking. You can put the patient in occlusion. The denture should not move. And then you take the denture out. Now, sometimes if you have bone reduction and there's a shallow vestibule, normally that's a contradiction, but you may find that the pin guide does not seat until you've reflected, but most of the time it will. All right, so you've established that the denture is, or that the pin guide is fitting, all good. So then proceed with the typical, if you wish, the typical crestal incision. All right, now this crestal incision is going to go from the terminal part of the fixation base all the way around to the terminal part of the fixation base, because you could have taken a surgical marker and marked in the distal extension of it and perform a crestal incision. And this is the most common method of laying a flap. This way you have the full palate and the lingual tissue to support the pin guide, and then flap forward and reintroduce the pin guide. Now there are other methods for pinning. For instance, here, this is not a flapless procedure like others, but you would introduce the pin guide and the fixation base, put the patient in occlusion, drill right through the tissue and pin, and then you can perform a labial flap just above the metal or at the metal. And one of the drawbacks with this is that you may end up with sutures that are a little bit apical to the prosthesis. So that may be just a comfort issue with the patient or some sutures that are irritating. But certainly you'll have a pin guide that seats solidly. Right, so this is a nice way to do it, nice way to perform it. And you also will ensure that you have the right type of tissue around the multi-unit abutments. And some of this is preference, so I don't want to definitely put a philosophy in your mind. Just kind of want to share the different processes, different modalities that you can lay a flap. Here you can lay a crestal flap if you, a labial flap if you wish, before. You can also perform a flapless surgery, and this would be if there's little to no bone reduction, right? So you could lay a little crestal flap here where there is some bone reduction and reduce it, and then do the rest of it flapless, or do the full thing, the full surgery flapless, Just depends. Usually on bone reduction. In a situation like this here, where there is lots of bone that should have been removed or should be removed, this will be a different type of prosthesis if you decide not to do it, not to remove bone. This is more like an FP1 design where there's no carrier guide. Okay. Um, and if you get in this situation where for some reason a decision was made not to flap, then there's going to have to be a modification during the surgery, right? Floating a prosthesis, but not ideal, not ideal. And we should talk about that if that's a process that you want to follow. All right, different flapping techniques. So this technique was the typical crestal incision. Pin guide was introduced. And at this point, you would take your Surgimat and you would follow long, short, A, B, C, D. You could see where the anatomy is, where the pins are going in. Obviously, there's nothing to extract. And so that's the legend for the pin guide. Also on the Surgimat is whether it's long or short pins that you're using from the fixation kit. So these are all short, right? So that's up on the Surgimat that's either on the wall or on the cabinet. And then this image is right here, right, for the pin length. And then on the left-hand side, what the pins look like inside the bone are on this area here on the left, because the Surgimat goes from left to right as you work through the surgery. Right. Once you are fixated, right, the fixation base is seated, then you can take an occlusal view just to make sure that the pin guide is in the proper position, right? Floating guide technology, there's a gap between the fixation base and the bone, and you'll be able to view back and forth, looking at the Surgimat, looking at the bone, is this in the right place? With edentulous cases, obviously the pin guide could move around. It could. Now, normally you put a patient in occlusion. In this case, you would seat the patient's partial, put the patient in occlusion during pinning, which really should have talked about in an earlier slide. And then the staff, somebody on the staff will hold the patient closed during the pinning process, right? As opposed to just holding this apically to the tissue, you put the patient in occlusion, close them down during pinning. Right. So it could also move around because it's on soft tissue, right? The least accurate surgical guide is one sitting on tissue. So you want to be careful with that, and then you want to confirm that the fixation base is in the right place. Then you will reduce the bone, right? Reduce the bone down, and then you'll try in the carrier guide. And here's the bone that's to be reduced. Okay, and then here is the carrier guide. Now this image is not on the Surgimat. I'm just sharing it just so you can see how visually what this looks like. The pin guide will be seated, and you want to make sure that the pin guide is sitting uh, on a fixation base, that it is seated, it is clipped in with the chrome locks, and there is no wobble. There is no bending and not forcing this in. So the only thing that can hold up a carrier guide is tissue or perhaps bone inside of the chrome locks or bone itself, just not enough bone reduced. All right, so just look at those three things. And once you've addressed those, maybe pinning the tissue back more or adjusting more bone, the carrier guide will seat. And the purpose there is to know that you've reduced enough bone to move on to the next stage. The next stage is osteotomy drilling. With our system, the GuidedSMILE system, the round, the sleeves without the nubs are for straight implants, and the ones with nubs here in the posterior, here's an image of it. Here are the nubs. Those are angled multi-unit abutments, and these are straight multi-unit abutments. And you can also make a visual here that your osteotomy guide is in the proper place, because you'll notice if you're looking at this at a certain angle in surgery, you'll think that this is too far labial, but in fact it's the trajectory that's aiming it back to the bone. All right, so that's very important. And if it seems as if it's in the wrong position, drop a tool in. This is Hyasin Achilles kit. Drop a tool in and just make sure your burr is touching the bone. Or maybe it's a reduction burr, a starter burr, and you'll see that it's should be in the right place. Right, sites are drilled, implants are in. Next step is to put the carrier guide in, seat the multi-unit abutments. Here it's kind of nice. This is the best angle to notice, but this is where you would look at the carrier guide image and you can see if there are any issues with rotation, especially in the posterior, where you have angled sites. You can see this one's tipped in a little bit, not the same trajectory flare as the rest, but if you'll notice, that's how it was planned. Tipped in a little bit. That's where the bone was. Otherwise, case looks perfect. Right? Carrier guide is still in. And then the temp cylinders were added. Didn't show that part of it. Temp cylinders are added. Prosthesis is picked up. Just simply backfill the stellar material of choice. Take it back in the lab, finish it, screw it down, deliver it. A little bit out of order here. So this is where you would backfill around the temp cylinders. And obviously you should have the blue plugs seated here. Deliver, and the case is beautiful. Doctor did a wonderful job. Nice improvement for patient. And that is a single edentulous maxillary case work through. Thank you.